As you know, Teresa LaFromboise, I am a professor in the developmental and psychological sciences area within the Graduate School of Education at Stanford University. And I chair Native American Studies, which is within the Center for the Comparative Study of Race and Ethnicity in the School of Humanities and Sciences at Stanford. I live and work on the unceded ancestral homelands of the Muwekma Ohlone tribe. And so I'm very grateful for the opportunity to be able to live and work here. And because of that, I feel a responsibility to contribute in some way to Native American students while I'm here. And therefore, that's one of the reasons that I have worked for 16 years with the Native American Studies program, which offers them a major and a minor in Native American Studies for students. And of course, teaches many courses that a lot of Stanford students campus-wide take. I want to thank the National Academies of Science, Engineering, and Medicine for this opportunity, and certainly thank the planning committee that recommended me. I'm very grateful to be able to talk about the work that I've been doing for quite a few years in schools. Next slide, please. I can have this. Thank you very much. I was asked to talk about suicide prevention in schools and then also to talk about implementation issues. So that's what I'm doing. I was able to give a presentation a few years ago at the Center for Disease Control and Prevention about schools as an important context for suicide prevention. Now, I realize I'm biased, and part of that is that I began my career as a middle school teacher on the Turtle Mountain Reservation. I then went to teach high school. I was a Johnson O'Malley teacher in Mount Pleasant, Michigan, working with students from the Saginaw Chippewa tribe and the parent committee from the tribe. And then I went on to get a PhD. Within the School of Education. So I'm biased towards schools, and I want to try to get this mission home. And at the time that I was asked to, do this presentation, it was, kind of sad for me that the American Foundation for Suicide Prevention only identified healthcare programs or systems and emergency departments, correctional systems, and firearms as critical contexts for suicide prevention. Since then, just looking it up the other day for this presentation, I wanted to see if anything had changed. And fortunately now, the American Foundation for Suicide Prevention does indicate that social-emotional learning is a promotive strategy or recommended promoted strategy for suicide prevention. I'm really glad to hear that. But if you think about it, since 1984, there have been school-based suicide prevention programs in this country. And they were developed because of a rising trend in industrialized nations, or Western industrialized nations, for suicide among students. And they realized that this would be an incredible place to be able to work with people who are very vulnerable, high rates of suicide. The rationale for schools as sites for suicide is based on the recognition that there's a significant amount of suicidal behavior occurring among students who ostensibly seem to be very well functioning, but yet they still do struggle with suicidal ideation and suicide attempts. So when we were invited to develop a suicide prevention program by the Zuni Pueblo and the superintendent of schools there, I tried to search what school-based programs existed, and at that time I was able to find one out in California schools, only one at the time that was school-based, and now there are quite a few. When I was invited to do this, it was really a gift. I was a member of a committee. It was called the Zuni Stanford Committee, and it was made up of faculty at Stanford and leaders of the Zuni Pueblo around issues that Zuni wanted addressed. it wasn't a matter of having a grant and going to a community to try to implement it or having a research study I wanted to do. We were at the behest of Zuni, and member faculty all over campus worked, there with them. Not a large number, but the ones that did were from the communications department, provost's office, archaeology, medicine, and then the School of Education. And so the superintendent of schools at the time for the Zuni community was Hayes Lewis. His father was the governor of the Pueblo, and they were very concerned because they had lost 5 high school students the year, in that previous year to suicide. And the community at that time, residents at Zuni was about 7,000. So they were very much affected by this. And they didn't want an outsider like me coming in. And they had been trying to decide what to do for a year. And they finally decided, well, I guess we will see if we can find someone that would act as a consultant, and maybe help us with the situation. And I was, invited to come with my students. So we developed a universal suicide prevention intervention that was available for all students in the high school. And I want to emphasize that this really was a community-driven and culturally grounded intervention. Although it's called Zuni Life Skills, the Zuni people labeled it that. I think we started out with something like suicide prevention, Zuni suicide prevention, and they scoffed at that and said that this has to be about life. And I know many of the presenters have spoken about that, and I felt foolish whenever they mentioned it, that I hadn't considered it. But definitely it's life skills. And I also want to say some people have talked about culturally adapting sort of mainstream interventions. And this is not a cultural adaptation of Gil Botvin's life skills training. He developed it around about the same time we were developing, but this is not the same at all. This was developed by the community, my team, along with some people from the Stanford Health Promotion Resources Center, and many, many sessions with members of the Zuni Pueblo. Next slide, please. I'm sorry, I didn't ask for the slide. This is a picture, and I want to pay tribute to Zuni for allowing us to do this, and hopefully other communities appreciate that as well, because we were able to go on and then make it more general for different tribes, and many tribes have benefited. Well, I hope benefited from it. I think they have. The fact that it still exists, I guess they do. Can we have the next slide, please? The emphasis now so much is on culture as prevention. And I just wanted to have this placeholder here to again emphasize that there was a lot of cultural knowledge conveyed in this curriculum, primarily through the scenarios that we use in the curriculum, and also through the selection of which activities we would use. We emphasize, and I want to say that after developing it, pilot testing it, and evaluating it over a 3-year period of time, we then went to Sequoia High School in Tahlequah, Oklahoma, and evaluated it there at Sequoia High School, where there were some 20 different tribal students from 20 different tribal groups represented. And then we, with the permission of Zuni, broadened it to include American Indian life skills, but the foundation of it was from Zuni. So now I'm going to mention it as AILS, American Indian Life Skills, emphasizes positive cultural teachings. And and the 3 that are most obvious to me is that we have lessons before we begin the suicide prevention section on grief, appropriate grief, and different cultural beliefs around appropriate grief from different communities. And with the invitation that the person who's using it would know and research and get information from cultural leaders in their community about what is appropriate grief in their community, what the students are using. We also ask for from Zuni their recommendations in terms of ways of coping. And this has a very problem-solving orientation. And actually, it was through their rank ordering what they thought were the most important coping strategies. And they said, we want our leaders, our future leaders, to be good problem solvers, and that's the primary one that we want. I said, well, let's take 3, because maybe the students will remember 3, and they gave me, the suggestions for the others. But they definitely prioritized the coping strategies they want us to use. And then another example that seems to always come to mind is the issue about anger recognition and expression of anger, and it seems to be so varied in terms of different cultural groups, and it really is, kind of grounded in what is appropriate here in this situation. So there's many things that need to be evaluated in terms of how do we use it here in this particular community. So I think there is deep culture there, and then obviously, some of the kinds of things of, it feels more reservation based than broadly about rural and reservation settings and urban settings, but that's more the surface level. Can we have the next slide, please? I'm going to get to implementation issues. I just want to share this logic model, and it's really so. In essence, the core of it is from a stress coping perspective. And I've just emphasized, the duality between avoidant and approach coping in this model to keep it simple. But we know that, every community has culturally sanctioned coping mechanisms. And to say that approach coping is ideal is not fair. Although what I was seeing in the work that I've done in all these years is sort of a pattern of, there are these risk factors, and I've just listed a few. And the reason I have these here is mainly because there are studies, risk factor studies, looking at each of these areas now with Native American adolescents, which is wonderful, because when we began, there was only 2 studies on risk factors with adolescents, Native American adolescents. But anyway, I see a pattern more of a stressful, so people have some risks. Obviously, everyone has risks, but more pervasive risks in Native communities. Stressful life event happens, and people, a lot of the youth that we were working with tended to want to avoid, to isolate themselves, self-medicate, and then which led to the suicide attempts. And we're trying to reverse that. We're trying to emphasize things like understanding oneself better, taking direct action, being aware of emotional arousal, being able to discuss problems with others, seeking support from family and friends, even self-distraction. Now, all the work on mindfulness is a way and approach coping mechanism. And then, for some situations, it might be advised that non-action, which could be seen as avoidance, but it may not be, in that it's sort of wise understanding or acknowledging the nature of things, and that some things are not, are very slow to change. So this is different than social withdrawal and rumination and feeling helpless and taking, self-medicating and those kinds of things. So we're trying to look at a healthier coping style. Okay, next slide, please. So these are the sections of the curriculum, and just a couple of things I want to emphasize. There are approximately 44 lessons. It's a large curriculum, but you don't have to use them all. And these are the major areas, and building self-esteem, emotions and stress, communications, problem solving. We have some work on self-destructive behavior and how to eliminate it. And then the sections 5 and 6 that you see highlighted in green are sort of the conventional crisis intervention work that we see in many school-based suicide preventions and other kinds of suicide prevention interventions. And then we didn't want to bring youth through a curriculum and then just end it at suicide prevention. And so we have this wonderful section at the end about planning ahead for the future. Planning your life, individual and community goal setting. And I want to emphasize as well that sections 3 and 4 on communication skills, problem solving, I'm sorry, 2 and 3, emotions and stress and communication skills and problem solving, are really kind of classic social emotional learning lessons. We just didn't have that at the time we developed it. People weren't emphasizing that. Thank you. Next slide. Okay. So if we were trying to think, what is the, some people call it the sweet sauce. Or the active ingredients, or we'll call it mediating factors. Over and over again, we learn these different skills, but through an emphasis on positive thinking, incredible emphasis on positive thinking and problem solving. So with the section on depression, recognition and depression management, they learn how to manage depression through positive thinking and also through activity, which is, and solving problems in order to be more engaged and more active and more on to things to reduce depression. So it's kind of a pleasant activities, focus, behavioral focus, and then the thoughts change, but it still is looking at positive thinking and problem solving in that area. Same thing with stress management, anger regulation. Next slide, please. Now, a lot has been said. I remember Dr. Gaughan's comments from this morning about, well, how do we know if these things really work? And I'm going to show you 3 studies that have supported outcomes for American Indian life skills. But I'm going to, be clear, one of the reasons they don't get a lot of attention, and maybe the reason I'm the last person on the list here, is that these are quasi-experimental studies. It's been very hard to do a randomized trial that would be with an adequate sample size to be able to do that kind of study in my experience. And I've certainly been trying in Native communities. So this is the evaluation of the Zuni life skills after the final evaluation, in which we had a comparison group, intervention and comparison group, but we could not randomize. Zuni wouldn't allow us to randomize. So that's a weakness of this. And we had to then match the sample from the intervention and the comparison group based on their depression level and gender. So we had match sample. And we found significant differences between the 2 groups on hopelessness. The intervention group was less hopeless and more confident to be able to manage their anger. And it's also a mixed method study where we videotaped youth in both the intervention and comparison groups, randomly ordered after we had all the videotapes. And we found that those in the intervention group were better at pure problem solving with a peer, and also being able to use a 4-step plan for suicide prevention, suicide intervention skills. So we have behavioral and self-report information there. Next slide. This one is an independent evaluation. I had nothing to do with it except to receive the results, which thank goodness they were what they are. But this is not, there's not a comparison group. It's a pre-test, post-test study of just 10 lessons from American Indian life skills. When I do trainings, people often say, well, Teresa, we will never be able to get this many lessons in a school. What are if we had to choose, what do you think are the most critical lessons? And I have a list of what I think it's about 13 lessons that I think are critical. And so they said, well, we can do 10 sessions. And so they selected 10 of those 13. And we're able to go to 5 different high schools in northern New Mexico. And there were about 90 students in the sample. 50% of them did speak their language at home. So we have a sense that there was pretty balanced, more traditional students. And they did find that there was a decrease in hopelessness and a decrease in suicide risk over just 10 sessions, and an increase in an identity measure called public collective esteem, which is what I think other people think of me and my group, and self-efficacy. Okay. And then the next slide, please. And then this will be the end of me talking about American Indian Life Skills. This is another one. This is with the middle school version of the curriculum. And we had an intervention group only designed pre and post. And we did see change or differences, significant differences in ability to manage, self-efficacy, to manage depression, cope with stress, elicit community support, and elicit social resources. Okay, the next slide. So now we're getting on to intervention issues. This is, when I do the trainings, I do spend a lot of time now on implementation issues because it's very hard to do. And so these are the characteristics and skills we think an ALS facilitator should have. And this has come from different people asking me, we're about to hire a new behavioral health specialist, and we'd like them to be able to use ALS. What do you think we should add? What should be looking for in a job description? And so these are sort of our thinking about the different kinds of qualities that would be important for an ALS facilitator. I think the main thing is that the person is, in addition to knowing problem solving skills and group work and that kind of thing, is that they really are advocates for youth. They can really connect with youth, and also importantly that they walk the talk, that they themselves are living pretty healthy life. We have done a number of trainings for this over the years, regional trainings, on-site trainings, and now more recently virtual trainings, although I don't think virtual trainings are that ideal. And this has been used in tribal schools, predominantly boarding schools and public schools, and a little bit in BIE schools. But I wanted to share, let's see, the next slide. Okay, this is an example of the things that people feel that they need to be able to effectively use ALS. And part of that is it's a challenging thing to do on a regular basis, to do ALS and to focus on this. We've actually had teachers that have become the ALS teacher in a required ALS course for as long as 5 years. They were language arts teachers that were able to convince the principal that they should be able to do this because it does have a language arts background. But as you can see, you really need a credible interventionist that has experience working with youth, that hopefully would have some experience teaching school, some lessons. But we're never going to get anywhere in this work without the support of tribal leaders and also the educational leaders. And it seems like that's hard to get. Maybe you can get it from one end, but not the other. And so it really, that's definite if it's going to have stability in the community for a long period of time. And we have some places where it's been in existence for 20 years. So it has happened. And then, of course, with the evidence-based movement, we needed evidence-based results, which we feel we have. The permission to participate. We really emphasize now in terms of widening out in the community guest speakers. And that can, and elder involvement. And people, people that are, who's the person that does the best, visualization or progressive relaxation or understands, coping, is really well known for having coped with an incredible disaster, or people in the community that are open about the fact that they had attempted in the past and here they are leading very fulfilling lives. And then it sounds odd, but we need space for the intervention. And this is a place where casinos can be very helpful if schools are not allowing us to have space. Okay, I just want to go down a few more things. How much time do I have?
Dr. LaFromboise, we're actually out of time. If you could just wrap up, I'm so sorry.
Okay, I'm very sorry. Well, let me just say, in terms of barriers, one of the previous speakers was talking about it being easy to use and readily accessible and cost effective. Well, certainly this is cost effective. It is readily accessible. You can get it on Amazon or through the University of Wisconsin Press. But I think it really does take some experience teaching or running groups or being running a boys and girls club, basically experience with youth and with instruction to be able to feel comfortable doing it. I've had people that didn't have any of that background and said it took them a couple years, and then they really caught on in terms of feeling, comfortable using it, ALES. So that's one of it. Of course, we've talked about health and mental health inequities. So we know that we're operating with not enough money to be able to implement on a wide scale. Silos. It's very interesting how schools and behavioral health programs don't really interact that much, and that we definitely need to get away from the silos. There's also a question of what happens if we have non-native students in our schools, in public schools. And usually what principals will say is, well, is this for all of my students if you have non-native students? And we would say yes, that there's a way to learn, it's important to learn about some native culture, and for non-native students from all different ethnic backgrounds to learn and about native culture. And sometimes when people have done that, what they do is that they do some about native culture, but then they also emphasize more the psychological aspects of it, so that the children who are not native don't feel excluded. And also another issue is being able to convince educators that subjects that are not academic in nature are still critical, and that ALES fits very well in language arts and health classes, and that they are part of subject matter. So that's an example of some of it. And I think, we've mentioned another obvious barrier is the taboo about talking about suicide. And so my bottom line here is that I would say that schools are often overlooked for sites, may have the final slide. Then that they're often overlooked to sites for prevention. I hope that increases. That we do have evidence that many youth have benefited from school-based prevention interventions, not just ALES, but sources of strength and some others. And that we are beginning to have more community-wide and family involvement interventions for suicide prevention. They're in Indian communities, they're increasing, but they're understudied. And so I guess I would really encourage us to think, if you look at all that's been presented today about we have the potential to do comprehensive suicide prevention. It's all there, it just needs to be coordinated. And that's what I would say. Thank you very much.